Well, I thought all the abstracts were interesting, but I particularly thought the liquid biopsy, the cell-free DNA testing in patients with unknown primary was illuminating. Again, we now know that liquid biopsies can be just as effective as comprehensive molecular profiling on a tissue biopsy specimen, although we really can't detect all the abnormalities that may be important, but it's coming along, and it correlates quite well with a tissue examination. And what was seen in this abstract in a large number of patients were many different genetic alterations which can be considered actionable or treatable. Several of these were what we call level 1 findings, which means that there's FDA approval for a particular drug that targets the genetic abnormality. I won't go into all the details of this, but in my opinion, this again represents all the different types of cancers there are in the cup syndrome. If you put them in a big bucket and stirred them around and then picked one of them out, and if you didn't know what it was and you did comprehensive molecular profiling, you would find certain genetic abnormalities or alterations for that particular cancer type. And it's very similar to a series of patients, for instance, with lung cancer, or breast cancer, or colorectal cancer. But because this syndrome represents a mixture of many cancers, those are found, and if one can find the tissue of origin, which often aren't even looked for in the past or not looked for, more oncologists now realize you can find the tissue of origin in many of these patients, and that's what's happening. A second abstract that I thought was interesting was the use of an immune checkpoint blocker, Nivolumab, in patients with unknown primary cancer. And this was an abstract from Japan, which included, I think, about 45 patients in the study. I think 11 were previously untreated, small number there. This is a phase 2 small study, but what it showed, even in patients who were previously treated, that Nivolumab produced some responses and clinical benefit. I don't think there's any doubt about this in some of these patients. Now, we don't know if this will hold up with larger numbers of patients with the cup syndrome. But again, I think it's along the same theme that I mentioned earlier. Cup is a constellation of many different cancer types, and some patients are responsive to immune checkpoint inhibitors, such as renal and lung cancer. Others are not responsive, such as cholangiocarcinoma in general, or even many GI cancers. Some are, but most are not. So if you treated all these different types of cancers that are within the cup syndrome with an immune checkpoint blocker, you would expect some of them to respond favorably, and that's exactly what happened. Only time will tell if we can incorporate this later, but my main message here is we need to find the cancer type, and then we can look at comprehensive molecular profiling to determine if we can then add additional treatments to enhance the overall benefit for these patients. But again, finding the cancer type remains a key element that is often ignored.